Hello, I am Eli Adashi, Professor of Medical Science at Brown University and host of Medscape One-on-One. Joining me today is Representative Phil Gingrey, a women's health provider and a legislator, now in his 5th term. Representing Georgia's 11th district, Dr. Gingrey, one of 17 physicians in the House of Representatives and co-chair of the GOP Doctors Caucus, brings critical insights to the Energy Subcommittee on Health, of which he is a member. Welcome.
Thank you, Dr. Adashi. Glad to be on your show.
It's plainly wonderful to have you with us. We are very keenly interested in all legislators, but especially physician legislators. In January of this year, you sponsored the Health Act of 2011, which seeks to bring about tort reform. Could you take a few moments to describe the highlights of that bill, what it seeks to accomplish, and perhaps the backdrop to what drove you to launch this initiative?
Ellie, what drove me to launch it, I guess, is 31 years of medical practice. It was not all in the specialty of women's health care, OBGYN. I was a Marcus Welby type family practitioner in a small town in South Carolina a number of years ago. But that accumulation of clinical practice and experience, and unfortunately a couple of trips to the state court in regard to medical liability cases, led me to know that there needed to be a leveling of the playing field, essentially. And what happened in California back in the late 70s, the MICRA was the acronym, Medical Injury Compensation Reform Act, was very successful. And the linchpin of that legislation was a cap on non-economic awards, so-called pain and suffering. Mm-hmm. There are other provisions in that bill that are in my current Health Act, help efficient, low-cost, timely, accessible health care of the 112th Congress, as you described. But it's been a long time. We've been working a long time. I've been in the Congress now for 8.5 years. This is my 5th term. I have actually authored this bill several times in the House, certainly during Republican control when I was first elected, and it passed the House only to die in the Senate. We feel that based on President Obama's comments, especially leading up to and during the deliberation on the Health Reform Act, we sometimes refer to as Obamacare, but the Affordable Care Patient Protection Act, PPACA, is the provision was sort of promised that there would be a section dealing with medical tort reform, realizing that, as the CBO says, Congressional Budget Office, in a bipartisan report, that it would save at least $62 billion over 10 years, and that's not chicken feed, that's significant money. I think, Ellie, much more than that. The RAND Corporation and other studies have been done that suggest maybe even $150 billion per year, not over 10 years. And the big savings, of course, would be in reducing the need for doctors, especially in high-risk specialties like mine, OBGYN, neurosurgery, emergency room physicians, to order so many things that we refer to as defensive medicine, to be able, if necessary, subsequently to defend themselves in a court of law, to say, oh yes, we ordered that test. But many times, based on their clinical skills and acumen, doing a thorough physical examination, and as you know, doctor, listening to the patient, many times will tell you pretty much what's wrong, and you know when it's necessary or unnecessary to order some of these very expensive tests.
To some, the issue of tort reform is a state issue. To others, as this bill would propose, a federal national solution is called for. How did you think about this issue and ultimately arrived at the notion that we need to go beyond the states and put on the table a national solution?
Well, it's an interesting question that you ask, and this issue did come up when the bill was assigned to the Judiciary Committee in the House of Representatives, a Democratic amendment to that effect, saying essentially, the 10th Amendment should restrict this kind of legislation to the respective states. The point, though, that the Commerce Clause, Article 1, Section 8, of the Constitution very specifically says that when you affect interstate, not necessarily intrastate, but interstate commerce, then federal law has primary jurisdiction. And in this case, particularly Medicare, Medicaid, the state children's health insurance program, or the S-CHIP program in Georgia is called Peach Care. All of these are federal programs. TRICARE, all of the military health care. You're talking about maybe 70% of the health care dollar that's spent every year directly or indirectly involves we the taxpayer, not just the citizens of Georgia. So under the Commerce Clause, clearly the jurisdiction is there, and it's necessary because, quite honestly, in certain states like my own of Georgia, where the legislature and the citizens of Georgia, not just the physicians that practice in Georgia or the hospitals domiciled in Georgia, felt very strongly the need for medical tort reform, not unlike the California bill, and it was passed by the Georgia legislature, only to be struck down within 2 years by the Georgia Supreme Court, implying that it was not constitutional according to the state constitution. So that will happen time and time again. States like Texas, of course, when they passed their tort reform legislation, it was by changing their constitution. It's very difficult to do that. So that's the reason why it's necessary to have a federal law. But the federal law would, in our bill, the Health Act, would not preempt if a state has already dealt with the issue of the limits, caps on awards for non-economic damages, we sometimes refer to as pain and suffering. If the state has enacted a cap that's higher than what's in the Health Act, $250,000, then the state provision would prevail. If it's lower, the state provision would prevail.
So the necessary provisions are in your bill not to override or preempt existing state bills.
That is correct.
Interesting.
Yes.
Yeah. As we speak, the bill has successfully received the endorsement of both the Judiciary Committee in the House, as well as the House Energy and Commerce Committee. Where does the bill go next at this point?
The bill will go to the House floor. The bill has been reported favorably from the two committees to which it was assigned. And now it goes back to the House, and it will be placed on the calendar. The timing of that would be dependent on leadership. This is H.R. 5, so it's, you might say, the fifth most important bill to the Republican House leadership, Speaker Boehner, and we will be, of course, communicating with leadership. I would hope that this bill will be on the House floor before, well, certainly before the August recess of this year.
I know it's difficult to foresee and or predict outcomes, but what is your best sense of the disposition of the bill in the House first, and then perhaps in the Senate?
Well, I think it will pass the House, and it's nice this time that it is a bipartisan bill. In fact, my Democratic co-sponsor, original co-sponsor, along with the chairman of the Judiciary Committee, Lamar Smith of Texas, is my Georgia colleague, David Scott, whom I served with in the Georgia Senate for a number of years and have served here in Congress with David as well. We are in adjoining districts in the state of Georgia. So I do believe that the bill has a great chance, and I think it will pass the House of Representatives with some Democratic support. The Senate, of course, it's going to be a heavier lift. We understand that. But I'm going to ask the President for his support. The President talked about it when he spoke to the AMA, the American Medical Association, a couple of years ago at their annual meeting, realized the need, promised to organize medicine, that there would be some provision in the Health Reform Act, some significant changes. It turned out not to be the case. A few pilot programs, $50 million over 10 years is really not very much. So again, I think the President realizes that there will be a shortage of physicians if we don't do something about this, and the real cost driver, well, it's not the price of a malpractice insurance premium to an individual physician. Sure, that might cause that doctor to limit his practice somewhat in regard to the high-risk patients not being willing to go to a certain state where there's a lot of frivolous lawsuits. But the real cost to the healthcare system, to Medicare and Medicaid and these other programs that we mentioned at the top of the show, is the very expensive testing, particularly imaging procedures. And that's why I feel optimistic this time, more optimistic than I ever have been in the past. So hope definitely springs eternally, and I think this might be the year.
Keeping the particular makeup of the current Senate, are you thinking of certain senators as advocates and or supporters? In particular, I'm thinking of the 3 physicians who serve in the Senate. Do you have any sense of how the Senate is shaping up that way?
Well, I think the physician members will be very supportive, and we are very grateful to them. They're strong in the Senate. Senator Barrasso is part of leadership now. Senator Coburn has been a very strong voice in the Senate, a conservative voice, yet someone, as an example, as a part of the group of 6 working on the debt and deficit solution, has a very close relationship, in fact, with President Obama. I think not only professionally but personally. So yes. I do think we have more leverage in the Senate now, maybe even than when our friend Dr. Frist was a Senate Majority Leader. So a lot of this, Ellie, as you know, is about timing, and this just seems like the time for meaningful, fair, and balanced medical liability reform.
Thinking about the President for just another moment, I believe the $50 million, at least in the fiscal year 2011 budget, have been erased in the context of the continuing resolutions. But there is, I believe, a request for $200 million in the fiscal year 2012 budget. Understanding that that budget is still very much in flux and is likely to be subject to significant adjustments, is it conceivable that that component of the legislation could be protected, at least in part, so as to remain true to the spirit that both the President and the House now appear to be supporting?
Well, I think so, but as you put it, true to the spirit, and the spirit is just not enough. I mean, we have had a long experience since the passage of MICRA. We're talking about 30 plus years
Yes.
of a good result. And I think it's time to act. I don't want to see us just kind of say, well, we're moving in the right direction. We've kicked the ball a little bit further down the road. I think it's time to act and pass this bill. And again, that doesn't prevent, as we said earlier, the states from looking at the caps and saying 250 is not enough. We need to go higher, as Georgia did, as Florida has done, as Texas has done, I think even as West Virginia has done. And the same thing in regard to some of the other provisions. We haven't talked about some of the other provisions. I guess the most significant one, though, is called flexi caps, so that the states do have that ability to go further. Say adjust for inflation and say that 250 was okay in 1979, but maybe it ought to be 350. Maybe it ought to be applied to more than one defendant, if there is, in fact, more than one defendant. And that's what a lot of the states have done. In medical liability reform, there is absolutely no change in regard to a patient's ability, their God-given right, their constitutional right, their state right to a redress of grievances in a situation where they have been injured by a doctor practicing below the standard of care for that community and for that specialty of medicine, a hospital also with the same culpability, that these individuals will and should continue to have their day in court. And economic damages, including lost wages, lost income, future medical care, future medical needs, whatever assistance, and these awards, judgments, settlements are many times in the millions of dollars. In fact, even in the state of California with the MICRA law, there have been cases where the award, economic award, could be $95 million, and yet the non-economic still be the $250,000 for pain and suffering.
Moving now to a slightly different topic, in another bill that you have sponsored just earlier this very month, you are attempting to address a state right issue, in a sense, a provision in the Affordable Care Act, which seeks to protect, if you will, the eligibility requirements for Medicaid, and has been a subject of some controversy and the subject of several bills, in addition to your own, with Senator Hatch having a standalone bill and Senator Coburn having a provision along these lines in his Medicaid bill. Perhaps a few words about what type of reasoning and thinking went into moving forward with this initiative in your mind.
We are very concerned about a provision in PAPACA, the Affordable Care Act, which requires the states to maintain their effort. The section is referred to as maintenance of effort in regard to rules and regulations of how they run their Medicaid program. When times were good, Ellie, when the money was flowing, almost falling from trees, states would apply under the Medicaid program for a waiver, it's called an 1115 waiver, to try to cover more folks than just those at 100% of the federal poverty level under Medicaid, more than just women with children, even to cover childless adults, and in some cases to go as much as 185% of the federal poverty level, maybe even 225%. And those waivers, although supposedly the requirement be revenue neutral, that you don't spend more the next year than you did the last, by the granting of these waivers, many states have received those waivers, and now they are stuck with them because of the provision in Obamacare, the Affordable Care Act, that says you can't, states, you cannot change that. You cannot even review your system of determining eligibility. You can't go back and say, well, 5 years ago, Mrs. Smith, you were eligible because of income for this program. What is your current income? Maybe that individual has since gone on to college and gotten a degree and is making $75,000 or $100,000 a year, and certainly doesn't need to be on the Medicaid program, possibly even has the opportunity to get health insurance coverage from her employer, but yet the states are prevented from doing that. In this bill, the State Flexibility Act would just simply strike that section and say, let the states continue to be the incubators of success and utilize their ability to design programs, and also, if necessary, to reduce their rolls of people that are on the program inappropriately.
Finally, and on a personal note, I believe our viewers would be equally interested to know, when did you actually decide to run for public office, and why?
I think when I had my first stroke. That's not very funny, is it? Stroke is never funny. No, it was sort of a not an epiphany, but just a gradual thing that happened in my life. I was a local school board member, a part-time job that really didn't take too much time away from my medical practice. I then became a state senator. And I would take a short sabbatical each year when the General Assembly was in session. And I got the bug, Doctor. I just sort of got the bug of public service and thoroughly enjoyed it, felt that I had a talent and ability to communicate. And while I no longer practice medicine, I'm not permitted to because I'm a full-time employee of the taxpayer. The decision to run for Congress, I think, was the right decision for me. But I will say that it was not unlike the movie The Candidate, starring Robert Redford. I'm no Robert Redford, but I think at the end of that movie, when he finally won that tough Senate race, he looked at his advisors and said, now what do we do? I had that rude awakening when I was elected to the 108th Congress back in 2002 and sworn in 2003. It's been almost 9 years now, and I'm finally working in a Good Samaritan clinic in my district for low-income, uninsured in most cases, and a lot of times Latino population. So I'm doing that once or twice a month, and I now remember why it was that as a young student at Georgia Tech, I made a decision to go to medical school and make medicine my career.
On that note, sincere thanks to Representative Gingrey and to you, our viewers, for joining Medscape One-on-One. Until next time, I am Adashi.